And Andrew, to move on from the first-line therapy, we spoke about sorafenib and we spoke about lenvatinib. Move to second-line therapy. One of the things, exactly as Rich mentioned to us at the beginning, was the rather surprising outcome, which was positive for regorafenib after exposure to sorafenib. Tell us a little bit more about that.
Yeah, so I think in the RESORCE trial, which has really addressed the value of regorafenib for patients who tolerate the sorafenib but eventually progress, and they get randomized to receive either regorafenib or placebo. I think the trial definitively demonstrated the improved survival. I think with that data, the drug was approved very, very quickly, and it was surprising for the following reason. I think if we really look at the structure of both molecules, they're actually incredibly similar. And I think we feel like how a drug with just a very, very subtle change can actually behave this way. But on the other hand, a subtle change does not necessarily mean the drug doesn't have any other unique mechanism of actions. So regorafenib definitely inhibits other important pathway, for example, the Tie2 pathway. So in the end, a positive study coming from the RESORCE trial really led the patients for the first time as a second-line treatment option. So I think for that reason, I think the trial definitely has its merit. And also, as Richard already published the data, if you look at the selected population, patient getting the sorafenib, when they fail, they get sequenced down to the regorafenib. In the selected population granted, the survival can be up to 26 months, which I think, for the first time we realize the availability of multiple drugs, I think it's really changing the life expectancy of our patients. We're going to discuss a little bit how do we optimize the sequencing, but I think with the availability of more than one drug, you're actually changing the natural history of the disease. And the safety profile of this drug, is very much known to the oncology folks because the drug, has been approved, in colorectal cancer, in gastrointestinal stromal tumor. So as oncologists, we know the safety profile very well. And I have to say that the safety profile for the HCC population, in my experience, and also based on the data, I actually think, it's manageable. I think you just need to be incredibly vigilant. I think you have to know how to deal with similar safety profile that we encountered, with sorafenib, the hand and foot skin reaction, the diarrhea. But on the other hand, if you're actually very, very much on top of things, I think these patients can actually get the treatment and also get the benefit.
So Katie, after REGO, clearly there was a lot of enthusiasm about many other drugs. And one of them that myself, we've been involved in is cabozantinib. Tell us about cabozantinib. What is it? And at the same time, tell us about the phase 2 data that you started with.
Sure. So cabozantinib, as you know quite well, is another multi-kinase inhibitor whose targets are similar to sorafenib and regorafenib, including the VEGF receptor isoforms 2 and 3 predominantly, but also includes MET, the hepatocyte growth factor receptor, as well as AXL and a couple other targets for inhibition that just distinguish it somewhat from the other multi-kinase inhibitors. And so cabozantinib was first studied in a large basket trial, a randomized discontinuation trial, which included HCC as one of the tumor cohorts. And in the single-arm uncontrolled phase 2 data, it did show promising survival approaching the 14 to 15-month range in the predominantly second-line population, and that prompted the development of the phase 3 randomized Celestial trial to study cabozantinib versus placebo in both second and third line HCC patients after first line sorafenib.
Sure. Rich, as an outsider to this, all cabozantinib data that Katie, myself, and many others were involved in, give us your perception. What do you see as that differ cabo from other TKIs, if you want to think?
Yeah, I gotta say that, even what has changed in the past 2 years, that we're all of a sudden having all these positive studies with TKIs, right? And initially, I thought when we saw the REGO data, as Andy alluded to, this is a similar drug to sorafenib. Structurally, though biochemically, it's a little different. The RESORCE study was very well designed in that there was stratification factors that we learned from other studies. It required documented progression on sorafenib, so it's a very homogeneous population, and it required patients to have tolerated a minimum dose of sorafenib. When that study read out positive, the feeling was, well, it's a good study design, and maybe the others failed because they were just bad study designs. But then we look and see the control arm in that study behaved the same as other second-line studies, and that makes you think that it was a good study design, but also a good drug. And then Cabo study was launched using fewer stratification factors, did not require documented progression on sorafenib. It was somewhat of the old design, right? Yet it read out positive, right? And it was as positive, I think, as Rego or any other second-line study. And I think it's very satisfying. I mean, I think it's another option. It's hard for me to differentiate the clinical activity of that drug from regorafenib, right? The data looks very similar as far as its tumor control, PFS, side effect profile. But the two drugs biochemically are very different, right? Both of them have that common VEGF stream. I'm interested to know the importance of hitting AXL and MET in second-line liver cancer, right?
Absolutely. If anything, one of the things that I would like to add here, if we recall all of us that there was another c-MET inhibitor, it's a multi-targeted c-MET inhibitor. It's not really specific for c-MET only, which was, devantinib. And that trial, devantinib versus placebo, was negative, while the one with the cabozantinib versus placebo, as we just heard, was positive. And an intriguing difference was that the devantinib required that patient will have c-MET expression that was measured at that time based on some data from the phase 2 as being 50%, 3 to 4 plus expression on immunostaining that will allow patients to get on the study. The smart thing that kind of, collectively we did in regard to the cabozantinib, we were agnostic to regard to the expression of the c-MET. And this really brings into play how much of c-MET is needed for the expression versus not. And remember, for example, in breast cancer, ER positivity, even a whiff of ER will be enough to really use hormonal therapy. And number two is, of course, we are very clearly understanding that this is a multi-kinase inhibitor. It's not only specifically a c-MET per se. That's really what kind of probably might at least allude to some of that positive outcome that the cabozantinib study had.